Welcome, everyone. Lots of people hopping on. We'll get started in just a minute. All right. We will get started. Welcome to our second webinar this month on community health workers. In this webinar, we have invited local individuals to discuss the innovative work they're doing and the impact it is having on North Dakota communities. My name is Mary Lizakowski, and I'm a Coalition Health Director with Foundation for a Healthy North Dakota. It is a nonprofit organization established in 2022 with the mission to promote health and wellness across North Dakota by working at the community level. We are growing a statewide coalition to enable local communities to collaborate and work together on common initiatives. And by becoming a member of the coalition, you'll be the first to know of webinars such as this, legislative news, as well as access to digital advocacy resources and toolkits. And just some housekeeping things. The webinar is recorded, therefore webinar attendees will be automatically muted for the presentation. If you have questions, please put them in the Q&A or chat box, and we will leave time in the end to address any of them. A link of the recording will be sent out along with an evaluation survey to complete as well. I will turn it over to Sandy to do the intros.
All right, good afternoon, everyone. My name is Sandy Tipke. I'm the Executive Director for Foundation for Healthy North Dakota. As we were talking about last week, the Foundation for Healthy North Dakota spent some time hosting listening sessions across the state. And what we found was so much good work that was going on locally by community-based organizations. And it brought to our attention the community health work and the community health worker topic, which also aligned with the 2023 session where the legislature passed a bill creating a task force to explore this topic and to create educational frameworks and reimbursement frameworks that they can move forward through next legislative session. So during our listening sessions, I was really fortunate to meet Sister Kathleen, and she was the Director of Ministry on the Margins, Director and Founder. So today I have the great pleasure of introducing Sister Kathleen, who's a Benedictine sister from the Annunciation Monastery in Bismarck, North Dakota. She's nationally recognized as an energetic and creative leader in hunger and homelessness education. She has developed service learning experiences for all age groups and led service teams to a variety of foreign and United States locations. Sister Kathleen has been a teacher at the elementary, secondary, university level and has served as a director of catechesis for the Diocese of Bismarck. In 2013, she founded Ministry on the Margins, which offers prison ministry, prison reentry support, a food pantry, a nighttime coffee house, support groups, behavioral health services, and street outreach. Ministry on the Margins currently serves over 1,600 people each week. A lifetime resident of Bismarck, she's an elementary education graduate from the University of Mary. Sister Kathleen holds an MA in theology from St. John's University and a doctorate in ministry from the University of St. Thomas. She's the author of several articles on spirituality and mission, as well as several podcasts and 2 books. Sister Kathleen serves as a member of the Burleigh County Housing Commission, Missouri Family Homeless Coalition, Burleigh Morton Behavioral Health Coalition, and 8 Inc. Board of Directors. And our second speaker is from the foundation. Elizabeth Pihlaja is a public health professional with a bachelor's degree in child psychology and a master of public health degree in maternal and child health from the University of Minnesota Twin Cities. Before becoming our associate executive director, she previously worked as a senior dissemination specialist with national nonprofit 0 to 3. She was also the maternal, infant, and early childhood home visiting McVie program administrator for nearly 5 years. She's been a DONA trained birth doula for over 5 years and is certified as a full spectrum doula through Zagdewin Indigenous Doula Training. And then finally, I will finish up after they both speak and talk about the current CHW task force and give an overview on how community-based organizations can attend meetings and contribute. So welcome, Sister Kathleen.
Thanks very much. It's good to be here. And to welcome people, and right up front to point out that there's nothing that says nurse or nothing that says healthcare worker. And so I have a huge appreciation for what it means to be part of the community and constantly collaborating. That is the gift that I think Ministry on Margins brings. We're unique in the way that we function, and that's got to go back to how we started. Because we're very person-focused. And think of yourself and those times when you think, I'm going to do something. And I had always been wondered about going to the prison, about volunteering, about doing something. And I finally picked up the phone 14 years ago and I said, hi, do you think there's like anything I can do? And they said, yes. And I thought, shoot. But I went into the prison. And if you've been at the state penitentiary or if you're working there, you know, as you come down the hallway, there's 8 gates that open and close as you get into the chapel area. And when it would open, I would walk through and it would close. Open, walk through, it would close. Think, this is really dumb, Atkinson. Open, walk through, close. Out of one of the hallways came this voice that said, hey, Sister Kay. And it was a kid I had taught as a 3rd grade student in Bismarck. And I didn't expect to be running into him there, although I knew, as we say, he had challenges. Little further, a big guy who had been in the gym a lot came and said, hey, sister. And it was a man whose dad had been a colleague of mine at a time of working professionally. I went into this area where we were gathering, and a man came bounding in and asked about my niece. And he had been in high school with her. And when I left with these people that were friends and colleagues and part of my life here in Bismarck, I wept. Because I thought there isn't an other people. These are our people. And not only that, but these are people who live holistic lives, not just split into this time of crisis or that time of history in their life. And hence, starting the Ministry on the Margins. Click, I need assistance on the technology. If you look here, here comes the first quiz of the day. And my bet would be that you could guess who the overweight middle-aged nun is in that picture, okay? But tell me, who has a felony as you look at that picture? Or who's a team member? Or who is actively in addiction right now and high on meth in that picture? One of the things that we do at Ministry on the Margins is we take that second word, let all be received as Christ, very seriously. And that all are all of our programs. I say it as you can be high, drunk, off your meds, in a crisis. You can't be a jerk. And that's been a huge piece of who we are, because we not only welcome people in, but we encourage people to come into the programs when they're in crisis, not when they get cleaned up or when they get their act together. Click. Here in Burleigh County, they've put together, the 3 functioning areas of community support. And we know, the people that the stable. But they'll need help most of their lives. They're going to need to continue to be on SNAP benefits to access daily health care or visits from the nurse, but they're going to do okay. And then you have this transition group who are getting their act together, who are making efforts to work with their health, who are trying to become sober and stay that way. And then down on the bottom, you have the people who are in active crisis. Whereas the mayor of Bismarck says, you know, the people whose lives are a mess. And they need to be cared for also. And so we've just identified ourselves as people who are actively seeking the people who are in the greatest crisis and mess. And that's who Ministry on the Margins serves. We fill in the cracks. What does that look like? Take a look at this next slide. And it's up there. We talk about not only all people, but a person as a whole. So the person is the center, not any program, not any place, but the person is the center. And if you look up at the top there, I mean, prison ministry is where we started. But right away, you have to remember that people who are in prison have family, and their family are at risk. And so a food pantry opens to help support that. Well, then along with the food pantry this morning, we had 107 people that came into the food pantry, but we also had food that we fed them and coffee. And we also had the Burdick County nurses who were here helping vaccinations. And so all of that is going. We also would have health needs such as women's personal items, things, blankets, all the type of stuff that's going to help me to live a more healthy life. While the food pantry is going on, we also take very seriously the need for community and joy. So there are bubbles, and there is laughter, and there's a checking in with some little surprises. So right there, you have a food pantry that's taking this very holistically and takes the person holistically. That would be in the prison ministry, and then a food pantry. But, you know, the role of incarceration is to help people move out. And so a prison re-entry development connects in there. And you're always thinking. And then if you look, well, if you're going to do successful prison re-entry, you need to help people to be independent, which would mean employment and which would mean housing. So here at the Ministry on the Margins, we have a real commitment not only to the employment of the people that we serve, but to the second chance employment, so that just about 50% of our 18 employees and team members are second chance or fair chance employment. What happens with life? We have a real commitment with those people that we employ to be paying not only a living wage, but to be having benefits. And many people are having benefits for the first time in their life, which then helps them not only to move as far as a physical health, but also things like paid vacation that you and I get, and we know how important that is to our mental health. It's also important to the people who are struggling and in crisis, that they have the same opportunities for mental health and for break that you and I have and expect. If you look down into that circle, well, that so easily then moves into not only housing and employment, but the supportive services, which we have here at the ministry, haircuts, an eye clinic, as I mentioned, vaccinations. We have acupuncture, person that comes in and offers acupuncture for people especially focused on tension and addiction. We have hand and foot care. Best holistic understanding. I came in one day to have a pedicure, And sitting in the circle with me receiving foot care was a man who had lost toes to frostbite. And there was a man with extreme diabetes. And there was a woman next to me and myself, and all we were doing was getting a nice polish and cut. And she turned to me and she said, "Hey, sister, are we having a girls' day?" And I said, "We are." She said, "I've never had one before," and just perked up into this beautiful person. Homeless, a lot of struggles, but she had a girls' day. She had a pedicure. So the supportive services always contact that whole person. Over on the side, then you have in that crisis area, 2 unique things that really not only bringing people in to the services, but going out, street outreach, going to where people are to check on them and to say, please, let's connect. The coffee house is something that was an idea 2.5 years ago. We're not a shelter, but we are a coffee house that opens at 10 at night until 8 in the morning during the winter or 6 in the morning now in the summer. And we did a pilot project thinking 10, 15 people a night here in Bismarck. Right now we have 70 to 80 people that come in every night, not spending the whole night necessarily, but they can come again in crisis or an emergency. We have a trained team that probably needs to administer Narcan 3 times a month. The connections with our emergency support services, with law enforcement, to give safety and rest to the people who are in crisis at the nighttime. And that's where our coffee house comes in. So ministry on the margins, our ministry not only serves all people, but we seek to serve all dimensions of what it means to be a person. One of the best descriptors, again, would be a man who said, "This is a good place. They treat us here like human beings and not homeless beings." That type of response and treatment of people, of course, happens huge, and the word was mentioned in the beginning there, with collaboration. The synergy, the creativity, the commitment that happens with collaborating organizations around a person who is united as a full person rather than divided into different spectrums. Not only with this type of concept do we have it, but we have what we call open hours. 2 hours this afternoon, where we will have social workers and people present for anyone to come in with any needs or questions. It becomes the "I don't even know where to start" type of question, so they're there referring. Of course, we're also serving ice cream this afternoon because we want it to be a place of celebration. But on Friday morning at 6 a.m., we will have somebody coming in, a care worker, who will connect with people, again, at their time, at their availability, not waiting until office hours, with the same idea of open hours. How can we help you? Where can we connect you? I know it's 6 in the morning, but let's stay here and do a plan for when the office hours open. That's that whole integrated piece. In the final slide, we've talked about and identified what is it we do best. We are available. We are fluid. We're a place where we really emphasize belonging and safety, no matter what that may mean. Non-judgmental emergency response. It could be Narcan, it could be some other issue, it could be needing to leave an abusive situation and you don't quite know where to go, but it's a welcome to all people. And you don't need to even seek help. You can just come if you want to be at that place. The other availability is meeting basic needs. And so if there are hours where we're serving a couple hundred households during the food pantry, that's good. And if it happens to be at 3 o'clock in the morning and there's a crisis, those people can also serve food. So it's the basic needs are available at all times. With that, that's our model. And it's the collaborative availability, the whole person. That's what's key for us.
Thank you, Sister Kathleen. All right, Elizabeth. And then we'll take questions after Elizabeth and I talk, and then we'll take questions as a group. Thank you.
Okay, let me get this going. Hi, everybody. Welcome. I'm really excited to be here talking about doula work. As Sandy mentioned in my little introduction, I've been a doula for over 5 years now, which feels surprising to me because it seems like just yesterday I went through the training. But I'm just so excited to talk to you about what I consider to be very important work in the maternal child health sphere and some of the exciting work that our foundation is doing around doulas. So this handsome little guy on the screen is actually my first doula baby. His name is Jack, and he will be 5 this summer. So again, just another shock to me as I was putting this together and really figuring that out and doing the math. Jack also has a new little brother. I was not there for his brother's birth, but I did provide some prenatal support, and I'm hoping to provide some postpartum support as well for that. So what is a doula? When we talk about this, a lot of people have never heard of it. It's kind of a strange word. So I'm always happy to kind of give just a brief introduction. So doula is it does feel a little strange on the tongue. It comes from a Greek word that translates to basically like female helper. I think I've seen some more direct literal translations of like maidservant. But basically a doula is a non-medical trained professional who provides physical, emotional, and informational support to folks during the contracted period of time. So we have doulas who work during the prenatal period and during labor and delivery. There are doulas who specialize in the postpartum period. There are doulas who help support folks who are transitioning out of this life as death doulas. And they all have their own very unique scopes of practice. So a doula in the context we're talking about is going to deal primarily with that perinatal period, prenatal through postpartum. In many cultures, during labor and the postpartum period, there are certain community and cultural practices and traditions that are in place to support the mother and the family as they welcome a new member. This can include things like special foods, drinks, cultural bathing rituals. In some cultures, it is recommended that the new mother stay in bed for a prescribed period of time, while other family members pitch in and support. We see in those cultures that women and babies tend to have really good outcomes. Unfortunately, a lot of those practices happen in communities that have a lot of intergenerational support. And I say unfortunately because we know that there are a lot of people around the world, and specifically in the communities we live in, where people tend to be a little more isolated in that time. It's just not the case that they have a lot of people on hand to help support with infant care, their own health needs, introducing a new member to the family, especially if there are siblings and other children already present. And as we know, when a new baby comes, the household demands don't stop, unfortunately. The world keeps going while you try your best to make everything fit. I don't know if anybody on this webinar has experienced having a new baby, in the hospital, in the birth center, And on the last day you're there, you package everything up. And I remember feeling like they're going to let me take her home. Like this tiny little creature. I came into this feeling fairly prepared. Again, when I had my daughter, my oldest child, I was in my graduate program. I had previously worked in a preschool and daycare for years, and I am the fourth of five siblings. So I had been present for several births and have helped with childcare from the time I was young, and I still just had this feeling of like, I I cannot believe that they're letting me go and do this. So where a doula can come in, again, we talked about some of the various kinds of support they provide: physical, emotional, informational. Really reiterating, doulas do not have a medical scope of practice. A doula's scope of practice can vary depending on the training they receive, the area they're really interested in working in, and if they are certified by any like organizational boards or certifying bodies. I have some generals of their scope of work under these certain categories here, but I really do want to emphasize that these are very general practices, and your own mileage may vary when either becoming a doula or working with one. As I mentioned before, also doulas may work in other areas that aren't represented on this screen. I know colleagues who are trained in other areas of support, whether that is being a full spectrum doula, you know, from prenatal through postpartum, stillbirth, loss, things like that. So again, there is a wide and varied availability of doulas for many different areas. But when we look at the doula work that's happening right now in North Dakota, and specifically with our foundation, it is primarily in these areas. So you see some things repeated through here: physical support, emotional support, advocacy, and a lot of connection to care and resources. So there are many different things that a doula may do that are hands-on, providing comfort measures during labor, providing emotional support that we know that other providers in that situation, say for example, if you're giving birth in a hospital, can't say enough about the good work that nurses do. We work with a lot of wonderful nurses. Two of my sisters are nurses. But, you know, I think nurses are up there with teachers as far as having so many things that they have to do on their shift, and just, you know, maybe not having all the time in the world they'd like to do all of those tasks. So ideally, a doula is a member of this care coordination model, of this care team, to help support the pregnant, laboring, postpartum individual, their family, in concert and collaboration with the medical providers in the room. And I just want to touch a little bit on advocacy, because that can be a little bit of a sticky point, depending on a doula's certification, their own personal values, and what their client wants. Some people take advocacy to be speaking, you know, to make sure that their client is being heard, for things that they may prefer, whether that refers to, you know, augmentation of labor, not having an epidural, having lights low in the room, things like that. And others take it to be a little more active in that. Ultimately, there are doulas who fit every different client. And if that is something that anybody on the line is interested in, I just recommend researching, you know, certifying models, and maybe getting recommendations to make sure that that doula fits the type of care that you're hoping to get. When we talk about doulas, it's important to talk about why they're important. Otherwise, you know, why just invite another person into your care team? I have a lot of people who say, well, my husband and I went through these classes, or my sister, my mom are going to be there to help me, so why would I want a doula? And to that I say, if you have supportive people who want to be there and provide encouragement and validation to you, that's wonderful. It's not something all people have. Also, in many cases, so my own personal experience again, my husband and I had gone through a lot of different classes and prepped for childbirth, and he did really great. He was a star pupil, fantastic with the breathing exercises. And in the moment when things started to go wrong, he kind of froze up. and that is not his fault. This is something for a lot of people is very new. It can be overwhelming. But one of my favorite things as a doula to do is to help support the folks who are in there, to help the laboring mother feel more comfortable, to feel better. Nothing is better for me than at the end of a birth, having a dad feel and know that he helped his partner through, and having the partner be able to reflect and not just think, he was sitting on the couch looking at his phone and didn't help me when I was upset. Ideally we come out and they both feel like they've been active participants. They have actively shared their support and love for each other in that situation. And I say partner, but that can, again, mean any support person, a mother, a sibling, a friend. Overall, we see a huge impact on health outcomes for women and families and for their infants when they have a doula in the room. And I want to be open about saying too that a lot of this research, especially earlier research, when we look at maybe like 2015 and earlier, looks at the impact of a support person, not always a trained and certified doula, but again, having just a general person there who you really feel is on your side, and they're able to speak up for you when you need that. More recent research is looking specifically into different trainings and other evidence-based practices, so we can see if there are things we want to move forward in the field with. But generally we see, again, lots of positive outcomes. We have a reduced rate of C-section birth, which I'm a C-section mama twice over, but it is a very invasive major abdominal surgery. So if we can avoid that and the complications that can come with that, it's better for everybody. We see a reduced rate of NICU stays. Doula-assisted mothers are 4 times less likely to deliver a baby with low birth weight. They're 2 times less likely to experience a birth complication involving either themselves or their baby. We see a substantial increase in breastfeeding initiation and duration. Again, it comes down to that support. You may have classes, there may be great community supports, but sometimes when you are home and you are in the thick of it and you are trying to make something work and it is difficult, it's really easy to do what works for you in that moment, and nobody is here to shame or say that that can't happen. But if breastfeeding is something that you really care about and a mother really wants to try and to make a go of, having somebody who is able to provide support, connect you to resources, and if they've been additionally trained as a lactation consultant to provide that in-home support, that can make a tremendous difference for mothers who decide that that's how they'd like to feed their children. We see a reduction in the length of labors and a decrease in augmentation, use of oxytocin to get labor going, use of epidurals. And again, this is not to shame or say people should not use medication, but we know that receiving an epidural changes the way that you can labor, some of the positions that you can use during labor, and sometimes leads to what some call a cascade of interventions. So again, they're not at any point meant to say this is the birth somebody should have, but if somebody does have specific ideas or goals for their labor, it's just having a trained person there by your side who can help you remember what you're going for, who can help you remember the questions you've had, and make sure that you are an active participant in this process and you don't come out of it feeling like a byproduct. I just wanted to talk briefly about the intersection of community-based doula work and community health workers. We're talking a lot about the great work that community health workers can do. Now, a community-based doula differs from what some may call like a private pay doula, or somebody who specifically serves, maybe more affluent populations. A community-based doula is somebody who ideally is from the population they're serving, from the area they're serving. They have a deep understanding of the needs of the area, the resources in the area, and generally they're trusted because they have that background, they have that experience. A community health worker we know is as a frontline public health worker, again, with that close understanding of the community that they're serving. And there's a lot of overlap for these. They're both individuals, or they're working with organizations that have trusting relationships with clients in the community. They both work as a sort of intermediary between either medical providers and the community or their client, or health and social services in the community. And they can help collaborate and communicate to facilitate better access to services, and sometimes to ensure that services are as culturally relevant and appropriate as possible. And we know that they both can build individual and community capacity by increasing health education and individual self-sufficiency through things like outreach, community education, social support, and again, advocacy. Where we talk about perinatal community health workers and where they really come into play are areas where access to doulas may be limited, either because of restrictions in funding, for a lot of people in places where Medicaid does not cover doula services, like North Dakota. You would have to pay out of pocket for that service, which sometimes is out of reach for a lot of people. I even say, before I was trained as a doula, when I was having my son, doulas were something I was aware of. I knew the benefits. I really considered it. But ultimately it came down to having a doula or having an extra week at home with my son before going back to work. And that was a really difficult decision that I wish I hadn't have had to make. And unfortunately, it is something that a lot of people do have to come to terms with. Is this something that I want that will benefit me in such a way? Or am I going to have a longer maternity leave? Or is this something that I want, but everything is so expensive now. I'm not sure I'm going to have the support to breastfeed, and I am going to be buying diapers and formula soon, and it's just an expense that I can't justify. So a perinatal community health worker would be funded through the same mechanisms that would fund community health work. In North Dakota, Sandy will be giving an update about our community health worker task force and looking at different routes and pathways to Medicaid reimbursement of those services. A perinatal community health worker has the general skill set of a community health worker, but with that specific expertise related to pregnancy, birth, reproductive health. Really quickly to wrap this up, just to talk about some of the doula work we've been doing. Last year, we received a small grant from the American Heart Association's Voices for Healthy Kids. That has allowed us to convene a multidisciplinary task force work group looking at, similar to the community health worker task force, different pathways to how we can establish a program in the state that increases access to doulas, that provides reimbursement for their services so they get hopefully a living wage for the work they're doing, and so that folks don't have to make those tough choices between living and having a support that can be hugely instrumental in how you feel about this change in your life, this change to your family, an immense time of transformation for a lot of people. Again, just having Medicaid reimbursement of that would allow many folks in this state to have access to this wonderful resource. So we've been meeting since October of last year, and we will conclude our work in June, at which point we do plan to continue meeting, but as a broader coalition that is interested in continuing to push doula work forward, and look at other maternal child health policy priorities. Out of this group, we will come with a policy brief with our group's recommendations for that Medicaid reimbursement, a roadmap of our progress in case it's something other groups might find helpful for them, and an issue brief that really looks into doulas in our state, what the gaps are, how we can make sure people have access to the service if they want it. I just really love this quote from Dr. John Kennel, who again is a pediatrician, researcher, founder of DONA International, which is a doula certifying organization. If a doula were a drug, it would be unethical not to use it. Again, the research is overwhelmingly positive toward doulas. We are working very hard to increase access to doulas in the state and to make sure that folks have the opportunity to have one if they so desire. I do have my email address listed on this slide. If you have additional questions that we don't have time for today, or if you're interested in joining that broader coalition, getting information about the work that we're doing, please reach out to me, and my colleague Shelley and I will be in touch and talk to you about, the best way for you to be involved moving forward. So thank you so much.
Right, great. Thanks, Elizabeth. So next, first of all, I'll mention that Mary has dropped in the webinar chat that if you want to learn more about the Ministry on the Margins and the doula work in the state, you can download our CHW Community Health Worker Guide that we've developed in partnership with ODDUC, and take a look at the great work going on. Sacred Pipe is in that guide as well, and I would encourage you to review it. So some exciting stuff that I really want to have almost like a call to action with community-based organizations across the state, because there's many Ministry on the Margins, Sacred Pipes, Native Inc. There's a lot of great work going on at the community-based level. And I had spoke with one of the task force members who works for Health and Human Services, and they do want community-based organization input as they move forward in developing kind of the guidelines for community health workers and what they're going to bring forward to next legislative session. And there are many meetings still, available for people to come in and to contribute. So I would highly encourage you to talk to people you collaborate with and other community-based organizations to start attending these regularly, so they get feedback from people who are doing the grassroots work and the effective work, and just reflecting on what Sister Kathleen was talking about as far as meeting people where they are. Having someone at the Ministry on the Margins at 6 a.m. in order to assist with coordinating of care is so important, to have the schedule that suits people that do need that extra help. And so I think that those are important things to reflect the task force, and I'm quite sure they'd be happy to have that information. What we will do after this webinar is ended is we'll send out, like we did last week, the links for the North Dakota Community Health Worker Task Force, the meeting dates, the timeline and deliverables that they're looking to. And there's also contact information for the person that is facilitating the group, so you can reach out to that person. They do request a few weeks notice if you have agenda items you'd like to add on. And you can also submit input as a community-based organization or as a citizen of North Dakota on what you would like to see. So I highly encourage that, just simply because they're looking for more input from community-based organizations. I think it's an exciting time in North Dakota that we're looking at this, and that the legislature passed this and they're putting forward this work because of all the meaningful work that's being done, and being able to build a system that'll have maximum impact for the people we're serving, which is what we all look for. So I think at this point, we will move forward and see if there are questions from anyone attending the webinar. And Mary, you can lead that part.
All right. So thank you for the presentation, and to you, Sandy. Before we move into the Q&A, I just would like to let you guys know that there's an evaluation survey up on the screen, so you can scan the QR code and take that while we move into questions, and we'll look at the chat box in the Q&A to see if anything has come in.
Sister Kathleen, I do have a question for you. I'm wondering, how did you come to the framework that you did when you started Ministry in the Margins, as far as knowing how to serve the people that you were serving from a person-centered, but also how you came to the spot where you were having the community-based workers show up at 6 a.m., right? Like, was there a framework that you started with, and what type of impact do you see as you're developing this? Because that 1,600 people is a lot to serve a week.
I think I love it. Is there a framework, like a great strategic plan or anything? Nope. Except now we've come to that point. It really would have been, that's why the origin stories has informed us so much. When we come to see people in crisis as people who are also in community and that holistic view. So it's not only people in crisis who are part of the community, but they all, I say, every person has a mother who is there. And so not to take a person out of that relationship, no matter who that person happens to be. When people make comments, say on social media, and say, well, they should, kill this person. They did a terrible thing. It's true. It's not excusing the action that they did. However, I want to say, there's a mom out there reading you saying this about their son or daughter. So there is a family. So always, and there's a victim with family. So that's a person to person. Now start to look at, when you focus on the person, you look at health as not only that homelessness is a huge detriment to your health and your chronic health and disease and longevity and addiction, but you can't separate each of those moments out. You just develop that holistically. I think we know what that means. Yeah, as Elizabeth was speaking about, you learn that in mothering, and no one gives you a chapter by chapter book of what's supposed to happen, right? And this is the time they are supposed to eat, and this is because that's life. When we begin to move that to a community model, and that's where community health is so important, there's no piece of the community that is not impacted. So that's really how we began and how we developed until we were able to reflect and say, now, what does that look like strategic plan wise? Oh, this is important. It's very simple. Oh, we have people who are homeless, have no place to go to the bathroom. Oh, that's a public health issue. It's that type of awareness. There is sometimes in leadership development or organizational development, they'll talk about it as emerging leadership or emerging style, which is much different than a top-down style. Let it emerge, go more organically, and people will come along and people will trust you because you prove yourself trustworthy.
All right, thank you. That makes sense. So it makes me think from a perspective of a community-based organization and serving people, how does serving the whole person transfer to policy to make this sustainable because it's effective, right? So, and
Yes.
how do we build that system? So that's what it makes me think of.
I think if we reflect back at I learned so much during the pandemic and the COVID crisis, and we ran into how do we put together a holistic perspective as well as structurally in policy. I mean, it's just a small thing, but it changed us here in Bismarck. I was asked, of course, we wanted people to remember to wash your hands, and there was all kinds of marketing and encourage people to wash your hands. And I was asked to read some of the signs and announcements to see if it would fit with the people that we serve. If they're educationally, can they understand it? And I said, no, until you tell me where they're going to be able to wash their hands, because everything is closed up. that, I guess, would be, a person's reality that changed policy, and then people go, oh, that's correct. Don't tell people to do things that you cannot make available to them.
Yeah, that makes a lot of sense. So do we have additional questions?
I'm not seeing any. Elizabeth, I have one for you. I didn't have a doula, but at reflecting on my pregnancies, I can see how it would have been really valuable. And I was just curious, where, like, when you were trying to connect and find one wherever you're at, how would you do that?
That's a really, really good question, Mary. So, oftentimes there will be a lot of word of mouth marketing with doulas. And I think many modern doulas utilize social media to share their story. Again, a lot of people go into doula work because they are interested in improving the overall birth and postpartum experience for families. And so in addition to announcing their availability and some of their own services, they'll provide a lot of information and education kind of that are, relevant in this period of time. And then through certifying organizations. So for example, we talked about the quote at the very end of my slide from the founder of DONA International. That is a major certifying body for doulas across the world. And they will, when somebody has finished their certification, they have a sort of a registry where you can look through and find folks. There are also certain websites. I think doulamatch.com is one that will, if a doula has a profile on there, they will help you find it, within a certain number of miles from your zip code, different search parameters like that. And then if you are in a state that does have Medicaid reimbursement, either through a state plan amendment or the adoption of some other coordinated care model, those states will often have a registry of doulas who are certified through whatever process that state has determined to be eligible for that Medicaid reimbursement. So those registries often are not inclusive of all doulas in an area, because a doula may make a personal decision that they don't want to be certified or don't want to, be eligible for that kind of Medicaid reimbursement. But those are places you can look. So again, you can just search social media, maybe doulas in my area, go to a formal certifying organization to see if they have a list, or look through a site like Doula Match to see if there's somebody in your area. But again, word of mouth is usually a good one too. If you know folks who have had babies or who are in that kind of early childhood, maternal child health realm, they will probably have the name of somebody they can recommend.
Awesome. Thank you for that information.
Yeah, of course.
I don't see any more questions. No questions that have come in, so if we can move on to closing. All right. Thank you so much, Elizabeth and Sister Kathleen, for this wonderful presentation, and to all who could attend today. To stay connected with us, you can follow Healthy NODAC on Facebook, Instagram, Twitter, and Foundation for Healthy North Dakota on LinkedIn. Also, to join the coalition, you can visit the link to stay aware of future webinars and updates on the foundation. And you have another opportunity to scan the QR code and take the evaluation survey. And additionally, there is a link to the reports and the Community Health Worker Guide, which all of this will be sent out in the wrap-up email as well. So thank you, everyone, and enjoy the rest of your day.
Thank you. Thanks, everyone.